Good evening, everyone, and good afternoon to Professor Bateman. Thank you for joining us for this exclusive conversation with Professor Bateman. We usually have an expert talk every month at the Green Oak Initiative, and this month we are we have a very special guest, and we are very honored to have Professor here. So the Green Oak Initiative is a community mental health team. And we are based in Frasertown in Bangalore, and we are a team of psychiatrists, psychologists, and counselors. And we provide mental health services to a range of age groups, and especially adults and older people. And quite a few of our clinicians work with borderline personality disorder. We also do group therapy and work with mothers and babies. Today's talk is in collaboration with the PARC, and PARC is our training organization that we're very lucky to have Professor Bateman come over a few years ago and through the PARC and conduct mentalization based treatment in person in Bangalore. And that's going to happen again later this next month, but in February. Today's talk is really for us to, for you to get to know a little bit about mentalizing and mentalization. And what we are going to do is we will have a little bit of an introduction by Professor Bateman to MBT and mentalizing. And then, depending on the time, I will present a case scenario, and then we'll talk about, mentalizing and the application of MBT in that case scenario. So we'll run through some case scenarios, and then we'll open it out to question and answers. If we will try and take a break sometime in the middle. So, but I will request you all to please mute your audio. And if when you're asking a question, if you're posting something in the chat window, then do introduce yourself. We're not going to be able to go around with a full round of introductions. So introduce yourself and just give a background to where you're working and what kind of group you're working with. So it helps to respond to your question better. And just be mindful. And at that time also, it'd be nice if your video is on. Okay, so without further ado, I would like to introduce Dr. Anthony Bateman, who's a psychiatrist and psychotherapist and a consultant to the Anna Freud Center, London. He, along with Professor Peter Fonagy, developed the mentalization based treatment, which we're going to talk about today. Originally, it was developed for borderline personality disorder, but over the years, it's broadened in its scope and is being applied to a range of conditions. It's been most researched in borderline personality disorder and has a lot of efficacy in research trials, which you may have read about. And I know from some of the group members that you've talked to me about it as well. Dr. Bateman is also a visiting professor at University College London and an honorary professor in psychotherapy at University of Copenhagen. He was also a member of the National Institute of Clinical Excellence. I think a lot of things have been added on to his introduction, but I must tell you that every time the professor has come to Bangalore or does run training for us in India, it's been very well received. And I'm hoping that, we all get something out of today's conversation. So thank you, Professor Bateman, for joining us today, and over to you.
Okay, so thank you very much, and thank you to PARC, Ashleisha, and colleagues, Pomina and Pavita, for inviting me. It's very kind of you. So I'm happy to be here. I'm sorry it's your evening. It's my work day, so I'm okay. You're using your evening, but thanks for coming. So just to mention, my internet was a little unstable this morning. So if I disappear, it seems to then turn itself back on after a minute or two. So I should reappear. So I hope it won't, but I'm sorry if that happens. Okay, so I'm just going to give an introduction. So I'm going to assume that you know nothing about mentalizing at MBT. So I apologize if that's not the case, but I'll try and make it comprehensible for someone who doesn't really know what it is. So I'm going to start with just what mentalizing is. Now, the first thing, the term is awful, but you will have heard of other terms which were in the literature earlier. Things like theory of mind is in the cognitive psychology literature. Theory of mind was an experimental paradigm, and it was used for studies of animals, really, of primates. And it basically looked at whether you could pick up that someone else would not hold the same knowledge as you. And so it was, as it were, a cognitive term, and it looked at cognitive development. Mentalizing came in, it was already in the literature when we said that this cognitive development that was being experimented on in this experimental paradigm was not just cognitive development. It was actually emotional development and subjective self-experience development, and it took place in the context of attachment relationships. In other words, this change to recognizing there's something else going on in someone else's mind, or they might hold different knowledge, was just part of an overall package of development. And we called the overall package mentalizing, which was already a term in the literature anyway. So we just, as it were, broadened the whole thing to take in subjective affective experience and mother-infant or child developmental capacities. So it wasn't just a biological cognitive development process. So that's where the term came from. So since then, of course, it's developed hugely in experimental terms, in terms of infant development, child development, adolescent development, and adulthood. So I'm going to give you now where it sort of got to about what mentalizing is. So if I can share screen, can I be allowed to share screen if you make me co-host or allow it?
You can go ahead.
Is it all right now?
Yeah.
Okay, thanks. There we are. Okay. So I hope you can now see that. And we're going to talk about mentalizing. Okay, so we actually took it up as not just a cognitive knowledge-based phenomenon, it's an integrative imaginative phenomenon. So it's the way the brain puts everything together and creates a picture. And it creates a mental picture in its imagination, in our minds, about ourselves and our experience and about others. So it actually perceives and interprets behaviors and information we're given in terms of intentional mental states. So it's sort of reading minds, but creating an imaginative picture of what is going on in those minds that explains, as it were, or tells us what makes someone do something or say something. And it also applies to ourselves. And these are called intentional mental states. They're about something. They're in a context of something, and they're motivational. So when you do something and I observe it, I purport in my mind a mental state behind that action. And that helps me understand the purpose of that action, or what's driving that action. And I also apply the same to myself. So I know what my current experience is, or what my current sense is, and that might link to an experience I've had in the past and so on. So it may piece it all together. So it's an imaginative mental activity. That's the first thing. And we all do it. And fortunately, most human beings are really good at it. We don't even have to think about it. We just naturally, developmentally acquire the skill over time. And what we know is that this process is strongly linked to attachment processes. So the attachment, as it were, drives our development of mentalizing. And secure attachment, in essence, equals secure mentalizing. We're good at reading things. We're good at reading situations. We're good at reading motives and so on in secure attachment. And we generate a capacity to trust in others because we can predict them. We kind of know what's behind it, so we know what might happen and so on. So it has a predictability in it. So what happens is what we expect, because we predicted it in our mentalizing process. So that's its breadth of definition: cognitive, affective, subjective, experiential. Now, we therefore use it in all our social interactions. So that mentalizing capacity has been divided into social mentalizing. What aspects are used in social mentalizing, in our interactions with others? Well, the first thing you can see here, not sure whether I haven't got it, but if you can see my cursor here, is I mode. So this is a component of mentalizing in social terms. What does that mean? It means that when I am somewhere or I'm interacting with someone, I am doing it. So it's I mode. I am a person, so I have certain characteristics. I experience myself in a certain way. So I have self-esteem, I have self-confidence, I have self-doubt, I have a picture of myself, both in the past and in the present. And I can tend to picture my I in the future. So if somebody says, what are you going to be like there? I can imagine it and I can place myself there, saying, well, I can describe myself. This is I mode. So I mode is a self. And it takes us across time. And this is mentalizing is required to create a self. So we create it over time. So we know who we are. So I look in the mirror, I'm the same person I was yesterday, not just physically, but I experience the same person. This is I mode, right? Now, this is very important because some of your clients, your patients will have a rather unstable I mode. They won't quite know who they are. So borderline personality disorder, by definition, is who am I? I have an unstable sense of self. I can be like this, then I'm like that. I don't know. I'm not sure. I don't know how I feel. So I is a particular problem, for example, in that way. So the core self can be unstable, but it can also be fractured and fragmented. So in narcissism, for example, I could have a very large I mode, which is rather self-aggrandizing and self-positioning. Self-esteem's over-exaggerated. My abilities I appraise as high and brilliant or whatever. But actually other parts of I mode are minimized. So it might become rather fractured or distorted. So I mode is part of social mentalizing. This is what I bring across time into situations. Now it interrelates with another component of social mentalizing, which is called me mode now. And in me mode, I read other people. Okay, so this is me now in the world, reading other mind states. How good am I? How accurate am I? How much doubt do I have? What's my level of confidence in it? Because moderate confidence, I assume I'm correct and I carry on. Okay, so how good am I at it? But me mode, in reading others, I also read them in relation to me, if I'm in a group or if I'm with a partner or with someone else. So I read other people's minds and I tend to think, how are they seeing me at the moment? Because that tells me what our interactive dance is and whether it's working, constructively moving forward and so on. So I tend to personalize also that experience of other people's minds. And that's called personalized me mode. So I can read them, understand their states of mind, just generally where they're coming from, what they're like or something. But I also personalize it. How do they see me? And this can influence my I mode. So sometimes how I'm seen by others doesn't really match my I. So I have to question and reflect on I. At that point, self becomes object. So self is now looked at. And that is the interaction between me mode and I mode. Okay, so this is going on all the time with your patients, those of you who are seeing them across time. There will be this interactive process where they personalize your experience of them, or they read it and worry about it or whatever they do. They also try to present themselves. This is an I'm presenting. How come you're seeing me like that? No, I'm not like that. I don't like that, or whatever it is. and things like that. So these are interactive, and they create, as it were, a stable I mode, we hope over time, developmentally. Now that bridges us, though, to what's called a social self of mentalizing. And this is related to actually engagement with others, where we experience a sense of being with them, not just interacting with them, but we now experience a sense of what's called we mode. And in we mode, we get an experience that actually we read them and we can read them reading us accurately. But at the same time, we also recognize they have the same matched experience. So the other person reads us and they can see us reading them accurately. And that joins us together. So we mode becomes a joint creation between two people, between a group, for example, where we recognize we may have different experiences, maybe about the same thing, but we don't merge those. We actually can both recognize that we're both recognizing them, if that makes sense. So this is called joint attention. It's a sort of just seeing to it. We can now jointly do something together. This is partnership. This is where we recognize each other's states of mind. It does become, of course, a sort of moment of we-ness, togetherness, intimacy, if you like. And we move, as it were, towards we mode, but we sometimes not in we mode and so on. So when we've got full social mentalizing that's stable, our I mode is actually interacting within the me mode process with someone else, for example, and that's fueling my sense of I, but also I'm understanding and we're moving forward. But when we're actually both actually together in not just back and forth, as it were, we become a pair, if you like, then actually we're something different from either of us. We're something created by both of us. This is the subjective experiential creation, if you like, and this is we mode. All right? So this is social mentalizing. So mentalizing has been sort of divided up like that. And this is clinically really important because, as I mentioned about borderline personality and I mode, but then, of course, what happens if I'm very inaccurate and insensitive about picking up other people's mental states, or I don't care about other people's mental states? I don't care what impact I have on them because I don't even bother to read them. So my me mode is, as it were, closed down. I'm then more likely to engage in antisocial than pro-social behavior because I don't care what the other person experiences. So who cares? It's tough, your problem, mate, and so on. So my me mode might be a major problem. But also, if I complain, my relationships don't work, I'm never understood by others, and so on, I'm never really bridging towards we mode. And if I can't do that, then of course I'm going to experience probably a sense of aloneness, or at least loneliness in some form. I'm not with other people quite. I don't have that capacity to have that level of intimate understanding jointly with other people in some way. So I may have a problem bridging towards we mode. So when we're assessing people in MBT, we're now trying to assess them certainly from these modes of functioning overall. And you do it mostly by collateral information, you know, around them talking about their relationships, their experience of themselves and so on, but you can do it very directly from questioning. So this is what we call social mentalizing. So we've got this general process, which I mentioned, which is here of mentalizing. This is the whole thing put together, but then we can break it down into I, me, we. These big social interactional components. So it basically looks like this in summary. Here's my experiential self, sometimes still called metacognition, but an experiential self is not just cognitive. It's an experience and accessibility of an existence of self, which is continuous over time. This is I mode. I read other people, and I may be good at that, so I can move forward conversationally. I can do a sort of exploration with them, no problem. And this is me imagining their mind, a first order mentalizing. But I second order it when I imagine them about what they imagine about me. I personalize it. So that's really helpful in terms of functioning in interactional process. And then also I can, of course, do it joint or we mode. Co-mentalizing is sometimes called a we mode mentalizing. But I can do one other thing just to mention, because it's important sometimes, is that if my friend John, I'm very close to, this is B here, this is John, and he and I get on well and we understand each other, but I'm also with him and with somebody called Jack. This is A, and I can't make Jack out. I will then say to John, what's Jack like? I can't make him out, say, and John will tell me. I will then believe John because I have a trust in John, because we actually recognize we actually understand each other's mental processes. So that's called vicarious mentalizing. I begin to understand Jack because John is explaining it to me. And we do that in groups, of course. We ask someone else to explain someone else to us and things like that. Okay, so this is breaking down social mentalizing. Now, if we move from the social interactive mentalizing down to actually intrinsic mentalizing mechanisms, if you like, these are the pathways the brain uses. What are those pathways? Well, we've divided those up as well. So to create social mentalizing, we integrate these different intrinsic mechanisms. We put them together and they function as a coherent whole. So we've divided them up into polarities that are paired together. And that's what these are. There's self-other poles, cognitive affective poles of mentalizing, automatic controlled mentalizing, and external and internal mentalizing. So we join those up, and when they join up, we can socially mentalize if they're in balance and if they're functioning appropriately for the context, because they're used flexibly, and we may overuse, underuse ones at certain times and so on. But there's flexibility and balance in them all. So we're interested in our patients about actually, are they overusing, underusing, not activating certain poles when they might? And they're paired together because they're often mostly activated together. So when we're thinking about something, we also are influenced by the emotion or the affect attached to that thought or that memory and that experience. So we join them and integrate them together. They usually function together. The same applies when we're thinking about ourselves. We use the same mechanism to think about others, particularly when we're with others, but also about others and so on. And we tend to overlap our self-representation capacities and other representation capacities. So they're joining together. So to understand other people's minds, there's a question still in the research literature about whether we imagine the other person's mind by activating our own experience in their shoes, as it were, or whether actually we're really just using rather more embedded experiences of things over time. So certain contexts, certain behaviors and so on, they simply activate that meaning, because that's our embedded cultural value to that action, saying, or whatever it is over time or not. Anyway, that's a different discussion. But these poles actually are activated generally together. So automatic is actually when we're simply making assumptions and we're predicting from that, and it works really well. It's very fast, immediate, doesn't take any time at all. Whereas controlled is when we slow it down and try and work things out. And we may work things out ourselves or with other people and so on. And external, internal is related to what the balance is of the information we're using. We're using a lot of external focus, facial movement, body posture, tone of voice that we're picking up, or are we using quite a lot of internal experience of ourselves about them, or asking them about their internal experience to explain what we're picking up from the external? And so on. So these are the intrinsic mechanisms. So again, in MBT, we're going to have to assess these, how our patients are using them, because they tend to get stuck, basically, or they tend to overuse or underuse certain polarities. And when they do, that leads to them mainly functioning in not what are called non-mentalizing modes. They're actually ineffective mentalizing modes because they're still mentalizing. They're just actually at a lower capacity of mentalizing. And I think these low mentalizing modes, which they get stuck in, are ways of the mind functioning. And they were sometimes called pre-mentalizing modes because they developmentally occur ordinarily, normally. But we then build on those rather than live by them, as it were. And in this case, we collapse to them. They kind of, they're like a ledge that we land on, so we don't go lower, as it were. And these are being called the psychic equivalents, teleological mode, pretend mode. And forget about those terms. And you'd be pleased to know that it was your groups in MBT that really popularized the word bubble for pretend mode. This is when the person lives in their own bubble. They're not in contact really with other people. They're just in their own mind states going round and round. It's ruminative, it may be over-rationalized, and it's separated off from the real world. It's not bedded in reality. It's just in imagination. So it's untethered imagination, gone forever, if you like. But they live in their own bubble. They withdraw, actually, is what your experience is. But then we've got the other two, which are psychic equivalents, which is simply where I'm inside my own head, and what is inside my head, what I think, what I feel, is a reality. That is what is going on in reality. Sorry. What am I doing here? Didn't mean to do that. Let me go back. There we go. So it is actually what's inside I see is all around me. And I see somebody's put in non-mentalizing mode seem like projection. Pretend mode isn't projected. Pretend mode itself is actually within. Psychic equivalence, in a way, is actually doesn't see everyone else as seeing things as you experience it. They just think you're wrong. So, for example, I might think that I know you don't like me, all right? That means that you don't like me or something like that. But I could say, look, that's not right, and so on. And you could say that's projective. But what if I say, I don't like myself, I hate myself, and that's in psychic equivalence. If I do, I am hateful. And there's nothing you can do about that. You say, but I have no evidence you're hateful. I don't hate you, whatever. They say, no, I know you don't, but that's not the point. You don't understand. I am hateful, and so on. So it's not quite the same as just projection, as it were. So this is inside out. There's a breakdown between my recognizing what I'm thinking, what I'm experiencing, and also how I see the world. The world is as I see it. There's no difference. Teleological mode goes the other way, and they often go together, in which outside, what happens in the world tells me what mind states are. So you're late, you don't care. It tells me your mind is you have no interest in me, or something like that. So outside, in. And these are sorts of mind states that people can get stuck in fundamentally. Sorry, get rid of that. I just want to get rid of that. Thanks. Now, just to say, as I mentioned, and then I'll stop shortly because I will then come to the treatment itself. But all this is bedded developmentally in attachment. So sensitive caregiving, we know, is really important. As it were, the minimization of trauma and trauma experience, which I'll come to. And what that does in the secure attachment and the sensitivity to the infant's mind, and recognizing the infant's mind as a self state and then mirroring that and all those things, leads to a sense that actually I can trust in the world and learn about that. I begin to discover myself as I am, and that pairs and matches. So it lays the foundation for actual self-soothing, for self-control, but also from learning from the world. And it does it by building mentalizing. So mentalizing fuels, as it were, the trust in the world and my ability to listen to others, particularly about me, and to be giving something to me that could be useful to me. So it creates a successful social world around me. But what actually happens when that's going wrong It mostly goes wrong through neglect, attachment, trauma, and those sorts of things. That leaves me in an unpredictable world. So my experience that you mirror back, you may mirror it unpredictably. So at one point I'm wonderful, the next point the same experience I have, but it's seen as different, and so on. So I have a disorganized interactive system. As a result, I can't trust in the world at all. And in not being able to, I can't open my mind to the world and listen. So I can close down, but I'm almost incredibly wary of the world because it might do something to me and make me feel worse, and so on. So actually what neglect and attachment trauma do is prevent me from actually calibrating my inner experience when it's overwhelming in some form because of my developmental level. It's overwhelming, but I can never calibrate it through the mind of someone else. So I'm isolated, I'm utterly alone in the world. And the importance of trauma is that the experience of the person is that they're having overwhelming states which are experienced alone. They're no longer within the attachment soothing system, so they can never be processed. So they continue to create disturbance and pain. So I'm left with uncertainty, vigilance, and so on, not trusting in the world, which is called epistemic dilemmas, or I can go the other way where I simply cave in, as it were, and I actually believe anything, because anything can be true. So I never question anything. And so I can easily be manipulated by others. But of course, whatever of these things happen, it creates a terrible problem in the social world. All right, so this distorts my mentalizing self-other cognitive affective mechanisms, my automatic mechanisms, my control mechanisms, so they don't work properly. I tend to rely on external focus, so I'm hypervigilant, and it's not working, so I root into psychic equivalence, inside out understanding of the world, or outside in understanding the world, or potentially close myself off into bubble mode, into pretend mode. So my social mentalizing is then disrupted. And that's where you see the relationship problems and so on. All right. So this is the trauma that creates the problem, because actually when I proximity seek within my attachment processes, I get into troubling interactions rather than soothing interactions. And then I get more adverse emotional experience. And this is what's happening in the personality trauma activation system. So I become wary and mistrustful and vigilant all the time. And at that point, our whole mentalizing is disrupted. So that leads me to how do you use that idea into MBT itself? So shall I just stop for a minute? There's maybe enough there to clarify anything, and then I'll just do 10 minutes on how we organize that into MBT, which is a whole training. But MBT, mainly for those people who have mentalizing pain and disturbance at the core of their difficulties. So that includes personality disorders. It includes eating disorders at the core of it. Substance misuse disorders are at the core of this problem. Often goes with, of course, personality problems and so on. They mix together. So MBT is used in all these conditions, but it's also been used in those that mentalizing is vulnerable and problematic, but may not be much more of an underlying core. So improving someone's mentalizing and making it more stable, particularly in social interaction, has been used in schizophrenia and chronic schizophrenia to help them with social adjustment, so they don't have so much social withdrawal. So they don't have so much experience of alexithymic experience and so on. And it improves their social interactional process. They become less anxious. And as a result, they have less admissions, because social activation, attachment activation, and high expressed emotion and critical comment interactive processes socially are very, very significant for creating breakdowns in psychotic action, and then towards admission. So stabilizing and mentalizing in a certain context, even though it's not the core of the condition, can be helpful even to that group. And these have all got randomized controlled trials behind them, by the way. So, and it's currently being tested in antisocial personality disorder, now currently narcissistic functioning, and so on. So you can see, because it's a transdiagnostic mental process system. So if you target it, it allows potentially to help someone stabilize how they are within the world and how they position themselves in the world and how they manage their own states of mind. That's the key to mentalizing. Okay, so after any further clarifications, I'll just cover then the translation in the clinical model.
Thank you, Prof, for that. Does anyone have any specific questions about mentalizing? If not, we can move on to MBT. Yes, Vidhi, do you want to just quickly give an introduction about yourself and then ask your question?
Hello, everyone. Myself Vidhi Khanna, and I am a clinical psychologist in District Hospital Sonbhadra. Sir, very well explained by you. So basically, I'm having a difficulty in understanding. Sorry. Polarity of mentalization. Sir, I'm having difficulty in understanding polarity of mentalization. Could you please explain it once again, if possible?
You're mute, Prof.
These are actions of mentalizing, so they're components. So for example, if let's take cognitive affective. So to mentalize in any context, really, I have to have some sort of cognitive capacity to appraise, to actually think about, as it were. But in order to do that, I activate another brain pathway, which is linked that to actually an affective processing system, the way to, that actually I can access a subjective affective state linked to that thought. So I tend to do them together. So I think I'm feeling a little upset about something. I don't know what it's about, but I feel upset and so on. And I begin to link the two. So you tend to activate them together. Okay. Now, we can move either way. We can feel upset, but have no idea why. And we can't work it out. We tend to respect that feeling, don't we? Or we could say, I am angry, but actually we don't really feel angry. Do you see what I mean? We can do all sorts of things, but usually we would integrate. So these are things that go together to create a picture of our experience at the moment. We do the same with the polarities, if you like, of self and other. So in self and other, I might represent an experiential self, but I'll at the same time activate an other mind. And I might be able to contrast what's in your mind, Vidhi, and what's in my mind, and see whether I can pick up better what's in yours, so I can, as it were, accurately address the difficulty that someone's having or something like that. So I tend to activate the two. So in order to understand the anxiety of my patient, I, as it were, place myself in the shoes and try and pick up their anxiety. But it's not a situation I would feel anxious about, say, for example, but nevertheless, I will try to do that and so on. So they tend to activate together, right? The third one is automatic and controlled. I can do all this in an instant. So it's like fast and slow thinking, if you like, but automatic is reflexive, immediate. It's beneath the level of my conscious awareness. So I'm simply doing it. So you're walking along the street with someone, you're just talking to them. You're not thinking, what's he say that for? Where did that come from? And so on. You know, you don't stop, you just carry on. And it's what Carla Sharp calls a serve and return. It's a to and fro. And it moves forward, it develops. It doesn't just go tuck, 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 tuck. It moves forward together, in a way, with the to and fro. So but that's automatic. But at a certain point, you might say something that I don't really follow. What? Where did that come from? What made you say that? I'll stop. Let's move to controlled. No, don't go further. What did you mean? I don't get that. That makes me think this. Is that right? No. Oh, you didn't mean that. Okay. So what did you mean? So we stop and we try to clarify, if you like. So we then use a different process, often a bit more cognitive, but not necessarily. We might use our affective response. You might say, when you say that, it makes me feel really hurt. I'm not sure what makes me feel hurt, but I am. Do you see what I mean? That we might not quite know, but we might stop. So this is the automatic controlled system. And then the final one is this defined as external, internal at the moment. There are others that people are trying to separate out, but external, internal is really the target of the information processing. So where do I get it from? Do I get it simply from an external position? I mean, in the world. So what you do, how you look, your tone of voice, your body posture, and so on. Okay. And we scan people because that tells us what's behind it. You know, we scan, and we got particular patterns as human beings of scanning. Interestingly, some people scan rather differently, and there's quite a bit of research coming forward now about looking at different groups and how they scan facial expressions and what they assume from that, and so on. It can be a bit different in different things. They're looking at it in offenders, actually, particularly sex offenders and other people. So this is the external focus, but we also are monitoring internal. So, and we usually expect them to match. So our subjective experience of someone's internal state actually usually matches what their presentation is. And when it doesn't, we're a little bit uncertain. Okay, so you seem calm and quiet, but I pick up that you seem explosive. Do you see what I mean? But there's no apparent evidence, but I do. The sort of sense, you know, when everything's quiet, it's a bit dark, the lights are a little dim, and you're walking along the street and you think, oh, it doesn't feel safe down there, but it's totally safe. Do you see what I mean? It's that sort of sense. All right. So these are what are called the polarities, and they pair together.
Thank you, sir.
Is that all right? Does that make sense? They're originally called dimensions. In the literature, you'll see them written about as dimensions. So cognitive to affective dimension. But trouble is, they're not dimensions in a way where one is low, the other is high, if you see what I mean. That's not necessarily the case. So they're better as polarities that work together.
And can I just add, or I don't know, this is kind of a question related to that. Previously, when I used to listen to you and attend the training, I used to think that, you know, we need to sort of, people with, say, who's not mentalizing is stuck in one pole and or the other, and we need to move them to the middle. But even if they're stuck in the middle, that's not necessarily very good either, isn't it? They need to be able to sort of move from one pole to the other and integrate it.
Exactly right, Ashish. Yeah, it's the flexibility that's important. Being in the middle isn't necessarily good mentalizing, because good mentalizing, effective mentalizing, better, is actually related to it can be context dependent. You know, if I'm sitting in an exam trying to retrieve memory and regurgitation, this, that, and the other, I do not want my affective mentalizing taking over. I'd much rather it was hardly in there at all, because I'll be too anxious and can't do anything. So out, let's get the cognitive system going, you know, whatever. Ramya?
Hi, I'm a counselor practicing independently. My question has to do with mentalizing difficulties. What I found very interesting is that you talk about ostensive cues. I want to understand a little more, and I also have a question about it. So what happens when the mother has PPD and maybe undiagnosed, untreated, and raises a child, and what happens to the cues there? I don't know if it makes sense in this context.
Yeah, well, there's two things there. Let's just be clear. Ostensive cues. Ostensive cue is a sort of catalyst. It sort of opens up the mind of the other person. So, and we can do it in very simple ways. So if I now go, Ashleisha wakes up, you see, because I've used her name. So in a way, that's an offensive cue. Oh, me? Oh, yeah. Do you see what I mean? But we do it actually in subtle ways. So we go, we point to, and they have an experience, however we do it, that this is for them, about them. They're now the center. Okay. So it gives them a sense that this is around them and for them. So it opens them up. We know this through experimentation, so we can get infants to we can influence them by giving ostensive cues or not giving ostensive cues. And they respond differently with ostensive cues than they do without ostensive cues. And you can look those experiments up. So that's one thing. Now you're then saying, well, what happens if the mum has borderline personality disorder? She may be at certain developmental levels of a child very good at the sensitive cues. They're very sensitive to others' mind states. In fact, they may spend too much time monitoring other people's mind states and kind of pleasing the other person. Do you see what I mean? So they actually can be very sensitive to it. However, they also can, other developmental sort of problems, find it utterly impossible. Because when they're feeling bad in themselves and it's in psychic equivalence that they've got low mentalizing, they may blame the child for creating that bad feeling in them. It's your fault I feel like this. Do you see what I mean? So they purport motives and aims to the child, which they simply haven't got. They couldn't possibly have. You see what I mean? So at that point, then you've got a serious problem in the person not being able to, as it were, look after the welfare and emotional needs and mind states of that infant because of their borderline function and things like that. So, but they're not inevitably poor at, as it were, giving ostensive cues and delivering good care. Their problem,
that's not lost.
It's not all. No, the problem is generally over time that they may under emotionally activating circumstances find it increasingly problematic.
Makes sense.
Okay.
And what happens when you say ostensive cues are not processed? So in other cases, can you help me understand that a little?
Well, if ostensive cues are not given, then it's likely that the person you're with, to some degree, will not really open themselves up to what you're saying or what you're talking about. So, in other words, if it's a mother-child and ostensive cues have gone, the child, as it were, is likely to become more self-sufficient. And there was an idea, which I don't think is accurate, that in these sorts of circumstances, they will simply build a narcissistic sort of self, that it just builds on itself. But I don't think that's true, by the way. But there was a suggestion of that. Okay. So without ostensive cues, you're unlikely to be able to join towards we mode function. All right, because you don't open up your mind to them and you don't experience them as opening up to your mind.
Wow.
Yeah, it's trouble. We fortunately, naturally, as humans, generally give ostensive cues. We look at the person we're talking to. That's an ostensive cue.
Yes.
And you know that actually when somebody doesn't look at you, if you've ever been with someone who has no eye contact at all, it's really quite disturbing.
It is.
Yes.
It is.
Yeah. So, you can pick it up. So that's when we have social cognitive problems. So that's when we move towards autism and things like that.
Makes sense.
Autistic spectrum phenomena.
Yeah.
All right. And then one finally thing, MBT and trauma. Yes, because trauma is the experience of not being able to calibrate with another mind, experiences that are overwhelming. So the person feels alone. So in fact, for mentalizing trauma, what that means is that experience is not mentalized. So what do we mean by mentalized? At that point, that trauma or the experience, emotional, affective, physical, and so on, is actually unable to be managed soothed in the context with someone else. So it becomes placed into some sort of mental arrangement. You know, so it doesn't activate the same experience. It is then mentalized. So I can have the memory, but actually it doesn't create the same experience. What happens in trauma is I have a memory or an activation of that memory through smell, touch, or whatever it is, and it sets it off in the present. It's psychic equivalence. It's here and now. Okay? So I therefore respond here and now. So I punch you if you touch me there and it created a sexual abuse experience. Do you see what I mean? Or I retreat or something. I have to act. Mentalizing it actually recognizes and places it in its context and allows it to be eventually actually reduced in its toxicity. So the experience is still there, but it doesn't activate to the same toxic level. So we do have a program for, as it were, mentalizing and trauma memories.
Thank you. That makes sense.
Okay, that was from La Pasua, I think. Okay.
Prof, I just have one. I don't know. Maybe I'll ask the question later. So if you're running short of time.
Yeah, let's take a. Is that okay, Bhargav? If we wait for later?
Yeah, that's okay. Yeah, that's fine. Yeah.
Okay.
So how about we take a short break now, and then we come back with the scenarios? Is that okay?
Well, shall I just do I'll just briefly
do the MBT.
Yeah, sorry, just better do them. Okay, just so people know what we're talking about.
Yes.
Okay, but look, the model, in a sense, is quite straightforward. So the first thing about MBT, and I'll be very brief, is that it's a structured individual and group treatment, sometimes offered only as individual, sometimes offered as only group. But the original research trials were mainly individual plus group together. All right. So what we do is structure it. So we have an introductory period, with treatment period, and ending period. All right. And we're aiming to basically engage, of course. We then create the framework with the patient. So we deliver some psychoeducation, and we then begin to formulate with them the problems within that framework, which is a mentalizing framework. And we then actually focus and work leading off from that formulation. And we're trying in the end to create stable mentalizing in which the I mode, me mode, we mode social interaction is more flexibly interactive, and also the polarities I mentioned to you are more flexible and interactive. So it looks like this. Formula assess their mentalizing and problems, not just their descriptive symptoms of their categorical psychiatric diagnosis, their borderline descriptor or whatever it is, but we will assess their mentalizing capacities, formulate that together in their own personal terms. Crisis planning, of course, is distinctly important. Framework is set up through the MBT introduction phase, and we have 12 sessions, 10 to 12 sessions on that, and then the exploratory phase. So we have interventions, but the interventions to try to help them stabilize mentalizing basically follow a particular model. It's very straightforward in a sense. And in fact, I wrote it down the other day. If I can find it, I thought, well, hang on, I've probably lost it now. I thought, oh, that's quite good. I write that down. And now, of course, I've lost it. Where have I put it? Anyway, it doesn't matter. It was basically, I narrate, so I'm the patient, I narrate, you reflect in a particular form. This has got a mentalizing reflection on it, and then I can begin to listen to you. So that's basically what we're doing. And this is I mode, me mode to we mode. So we're trying to always push towards an experience in the interaction, which all of you will do in your current treatments, towards a shared jointness of some kind. So we have mentalizing the relationship between us, but their relationships outside as well. We have exploration of their reading others and what they're like and what they actually, how they appraise that. And we also have interventions related to their self-definition, to their self-esteem, to their self-appraisal processes, and so on. Now, along with that, we actually focus quite a bit on saying, stabilize their processing first. If somebody's overwhelmed, anxious, upset, angry, and so on, you have to stabilize their processing. They can't remember anything or listen to you and so on. So we have to stabilize mentalizing processes, address any ineffective mentalizing modes, inside out, outside in, bubble mode, try to stabilize all that first. And once that's done, we can actually, as it were, begin to open up the narratives. And this is what you say, I reflect, you reflect on what I say, and so on. And that's within our relationship. So we target different areas. So there's some principles to follow. You can't stabilize mentalizing if someone's overwhelmed by emotion. So you have to be able to soothe, help your patient self-soothe, and soothe within the interactive process. Don't let anxiety get out of hand. Secondly, anxiety will get intolerable and painful if you're always in opposition, if you're not responsive, if you're not actively interacting with them. All right, so roll with their experience, because you're initially in MBT always moving towards their experience. They need to experience themselves not alone, and they can only do that if they recognize that you see them as they're experiencing something. All right, so that means there are mentalizing do's and don'ts. One is, don't join up with their low mentalizing. All right, and we can easily do that, which we'd explain maybe when we do some of the clinical discussion. But you do always monitor their mentalizing capacities. So if their mentalizing capacities are reasonable, a little stable, you can do a lot of therapeutic work. If they're unstable, you really got to try and stabilize them, and that's your aim. So we do all this through actually a series of interventional processes, monitoring their polarities, monitoring their low mentalizing modes, and stabilizing them. Right? And we do that through a particular exploratory stance. We do that by actually moving towards empathic validation of their experience, but also by particularly rebalancing their mentalizing dimensions or their mentalizing polarities, trying to get them in better balance in various ways. So we look at their emotional processing with empathic validation, keeping their processing so it's more soothing without getting too anxious and so on. And we have ways of considering that and working with their emotional narrative, but we also give them some psychoeducation in that. And the same applies to their relationships. We get them to appraise their own relationship style. We get them to consider their attachment strategies that are activated. And then we look at those as they're activated in their lives, outside, and in their relationship in the treatment itself. Right? So that's how we basically divide things up. All right, so it's structured, and then there's interventions across time, but it's all within a framework which is created with the patient, so it's highly collaborative. Okay, I know that's a big, just a general summary, but we can hear a little bit more of how we might then do something with some of these problematic patients that Ashleisha is going to discuss.
Okay, thank you so much for that, Prof. Are we okay to take a break? We'll take a 5-minute break if that's okay. I mean, 6 minutes. It's 8:04 in my clock. So if we can come back in about 6 minutes, that's 10 minutes past. That probably will be 40 minutes past for you, Prof. Yeah. All right. So yeah, thank you, everyone. We'll just take a quick break and then we'll be back soon.
Yeah. I don't know that we have enough empirical data to answer that, but there is certainly work being done by Martin Debenay in Geneva on mentalizing and schizophrenia, but that's not in the mums with schizophrenia, but some of them may be mums. But whether or not you might help them develop the capacity to, as it were, read self-states and other mind states separately might be something that could easily be worked on within this hypothesis, really. Certainly you could try, I think, but it would be an experimental question, an empirical question about how you would do that. So I can't tell you, I'm afraid.
Ashley, if we are not starting, can I ask my question?
Yes,
or
yes.
No, at the
Yes,
end?
you can. You can quickly.
Prof, I have a very basic question. So the understanding how we define trauma has changed over time. So we use the term trauma very broadly. So I just, is it possible to sort of clarify what's a very basic way to understand a trauma, like in the context of therapy and like in clinical practice?
Yeah, look, I think the easiest way, I mean, we're talking in mentalizing terms, not about event trauma.
Mm-hmm.
We're talking about interpersonal attachment trauma,
Mm-hmm.
right? So it's trauma within the relationship realm, both developmentally, of course, but even and later as well. So that's where we have an experience which overwhelms our mental capacity. So we can't process it. And in order to process it, we would normally talk with someone else or ask someone else. They will help us do that. So it's that trauma that we're talking about. Now, in a sense, we're therefore saying that any experience which overwhelms the current brain mentalizing capacity is a trauma. So we're all experiencing trauma. We just manage it through our mentalizing processes or the way we get help from others. So it's the processing of these experiences that create whether something is traumatic or not. Now, we know even developmentally in children that how their trauma episodes, let's say they experience sexual abuse, we know that actually parental or familial family sexual abuse is probably more toxic overall developmentally than a trauma from outside, sexual abuse from outside. Now, that's likely to be related to the fact that the attachment trauma, of course, is, as it were, more toxic, as it were, in the family. But also, if it occurs outside, it's likely to be processed differently, probably by a family that is functioning, or parents, or whoever. The environment around can help you process it. Do you see what I mean? But the events, kind of physical events, similar, perhaps. Okay, so it's very difficult, but that's why people have moved on to the complex PTSD sort of system, which overlaps with borderline personality disorder, because in borderline personality disorder, 60-70% have experienced significant developmental trauma. Yeah, so they have borderline symptoms plus trauma symptoms, and they're generally seen as complex PTSD phenomena. Okay, now it looks like there's an argument still about whether they're one and the same or they're separate and so on. My own view, for what it's worth, is they are distinct to some degree. They're not the same. So we don't get rid of BPD because now we've got complex PTSD. And we don't get rid of complex PTSD because we're having BPD. Do you see what I mean? I think they're probably different lines of things. Okay, but it doesn't matter to us in mentalizing that much, because we're not interested in categorical diagnosis. We're interested in how their mentalizing is functioning. And if your mentalizing is taken offline because you have an activated memory, then you're highly likely to have impulsivity or self-harm symptoms and other. Do you see what I mean? You still target the mentalizing.
Yeah. Essentially, it's unregulated distress if it continues. That's sort of what we're talking as trauma.
That's how it will show itself. Yes.
Okay.
Yes.
There's
and we
one
know.
more in the...
Yeah. Sorry.
So no, just Prof, there's one more question. I think if you could take that and then move to the scenarios.
There's this question about BPD, which we know, as Latika's pointing out, that Latika, I'm sorry if I pronounce it incorrectly, but it's not a single condition, BPD, probably. It's a range, isn't it? But I think it is, my own view is it is a particular constellation of when relationship functioning actually is mixed with emotional sort of capacities of regulation and some impulsivity. So once you get the three functioning together, and then there's levels of severity. But you're quite right that you can get different balances of those things. So where does MBT come in? Well, all the research shows that all those three areas improve to the same extent, really. So relationships, interpersonal measures improve across a year. Emotional management, all right, distress tolerance experience, anxiety management also improves, and impulsivity drops after 4 to 6 months. That's suicidality, violence, and so on. So it seems to have an effect in all areas, all right? And people worry, and the reason for that, I think, is because mentalizing is, again, it's not a behavioral construct, it's a meta-mental construct. So if we're stabilizing it, then you are actually able to manage yourself. You're able to self-soothe. You're able to not harm yourself. Do you see what I mean? It sort of follows down, as it were, to improvement. Okay. Now, that's why some people, though, say, for example, a behavioral treatment like dialectical behavior therapy is better for self-harm because it's a behavior, or suicidality. That is not borne out by the literature. So the reductions in self-harm and the effect sizes in MBT and suicide attempts are larger in MBT than DBT. Also, the trajectory of change, of reduction in suicide attempts, self-harm, and so on, is exactly the same in DBT as MBT, and so on. Now, there are bits of evidence that suggest Mike Crawford and another colleague, who's the first name in the paper, they did publish a little meta-analysis that thought DBT looked a bit better in self-harm and suicidality, but I'm not sure. I'm biased, so don't listen to me. But yeah, I'm not sure. I'm not sure their conclusions are really warranted. But anyway, who knows? All right. Was there any particular type of BPD you were thinking, or sort of style of BPD?
I think I was just worried about their somatic symptoms or somatization that can happen with BPD, and because I've studied trauma therapy, or like I was considering also maybe going in depth with IFS. So I was wondering if that something that is more a bottom-up approach would be more supportive for someone with BPD, because they're probably already living in their head so much that concentrating on something that is maybe CBT-like, MBT-like would put more pressure on their where maybe we want to move away and, let's say, also bring in affective, especially because you can correct me if I'm wrong, and others you can correct me if I'm wrong. I do believe that Indians are a little more emotional, and a lot more as a culture we don't tend to cognitive things as much as we move to affective. Just cultural differences. So I was just wondering if it would be just as effective here in India. And just wanted to know your thoughts, hence, about specific somatic symptoms and affective symptoms.
Somatic symptoms, I would think it might be. MBT is rather good on somatic symptoms because it tries to take seriously the fact, instead of bodily embodied experience, a somatic embodied experience, to make a mental representation of it. Because the reason somatic symptoms are there, if you like, with no medically unexplained and so on, is they don't have a representational mental level. So you try to build that and link that. So there are people who've tried MBT in Holland, particularly, with very clear focus on targeting somatic symptoms. and so on. To move embodied mentalizing, physical mentalizing up to mental representational system. And the other thing, remember, MBT is not quite like psychoanalysis, cognitive behavioral therapy, which is very much, you rightly point out, in the mind of the individual. In MBT, we're often trying to pull them out of their minds to consider other minds and so on. And we place ourselves in MBT in there. We say, well, hang on a minute. What I was thinking was, what do you think of that? Do you sort of mean? It's much more interactive, intersubjective, relational, to pull out from maybe their self-ruminative position. So we're not trying to push them back in.
Thank you for that. And if I may actually just bring in a case here, just so that we can, so it's actually, you know, something that's flowing on from what you're talking about in terms of relationship. And then you can maybe use that example to, so I thought if I present a brief summary of this case, and then Prof, if you can talk to a little bit about what might, where might be this loss of mentalizing and what could, some of the ways in which you could address it. So Mrs. AC is a 32-year-old woman brought by her husband to the emergency room. And you know, this is typically a kind of case that might be seen by a, say, a psychiatry resident or a psychiatry nurse in a emergency department, either in a psychiatry hospital in private practice in India, or like a busy teaching hospital and an ED there. So this woman, so this couple was having married for 3 years, and they got married by arranged marriage. So they didn't know each other much before they got married. And usually is the practice that, you know, if they might have seen a few alliances before they would have said yes or no. And so soon after, maybe recently, the woman found out that she hadn't been the first choice. That the husband had been interested in someone else, and she had said no. So this wife was his second choice, and so that had started making her more insecure. Since then, she would often get upset when he didn't buy her a gift for, you know, a random occasion. Or if he returned home late or traveled out of time. So this presentation had been triggered by after a fight that they'd had. She insisted that he cancel a work trip. He didn't want to. And soon after that fight, she said she couldn't take it anymore and had tried to cut her wrist. The husband got really worried and brought her to ED. So she's, you know, presenting with this impulsive, not being able to tolerate this distress and wanting to hurt herself. And it's not very clear, is she suicidal? Does she want to end her life? And this is the context. So it's not necessarily someone who's probably going to do therapy with her, but yeah, any thoughts on that?
Okay, so if I've got correct me if I've got some things wrong here, but I'm just going to go through it. So if you are now the clinician and you're in the emergency room, we have to assess this person. So we're, of course, probably going to see her, we'll see him, and so on and so on. And we've got a little bit of a history here that we know already that she's telling us in our interview with her that I discovered that I wasn't the first choice. And I have an insecurity all the time. And in MBT, we would explore that. We wouldn't assume what her insecurity was, by the way. Don't make assumptions in MBT. So we're now going to use our exploration, say, so in what sort of way? And this is what we call our not knowing stance. So we now have to interview her using a not knowing stance. That's the first position. So we're going to say, so you tell me you're insecure. Just tell me in what sort of way. When did this come up? And so on. Now, she then describes, let's say, she discovers this, however she discovered it. So we can then consider, what effect did that have on you? And so on. So we get to see her self-appraisal. Now, we want to know her self-appraisal from a mentalizing terms prior to this marriage. How did she see herself before this? Because now she feels insecure, unwanted, maybe a bit, whether she's lovable, however she's experiencing it. But we want to also know, well, what was she like before? Is this got a history to it? Or is this something that's created in some way new? Because that's quite important. If she's got a stable self-worth from the past, we're in much safer ground. But if she's got uncertainty about her desirability, her sense of being wanted, whether she's marriageable, I don't know, whatever. And now she's in this, we've got quite a long history of vulnerability in a way, and that might make things more problematic in our, in our future planning. So we're going to listen for that. We're going to use our not knowing stance to find out what the insecurity is around. Okay. Now, she then tells us, look, in this marriage, I get upset. He doesn't do this, and I get upset. He doesn't buy things, or he doesn't bring a gift, or he's late. Now, what are these things? These are things in the external world. So I'm just listening as a mentalizing therapist, that's all. And I think, so she understands his love for her through what he does. Did he bring a gift? Equals, yes, equals, he loves me. Did he come home on time? Yes, equals, he cares about me. Was he late when he said he'd come home on time? Equals, he doesn't love me. So she understands his generic mental states according to actions. This is what we call outside in. This is teleological. So she's operating on a teleological system quite a lot. So again, we take our not knowing stance and we simply ask her, we simply say, well, is this what tells you? Are you spending a lot of time wondering, well, is he doing this or not doing it, and what that means? So we want to find out how much she's using this across time. Is there any other way she judges his relationship towards her? I.e., a subjective experience of being cared about when he gives her a hug, when, some sort of more emotional, sort of subjective experiential state where she recognizes that he has care for her. Or does she have that or not, and so on? Because if not, she's generically falling away from any we mode into just a be mode, which threatens her I mode. So she reads him in teleological, you do this, it means that, about me. And then I'm in a very unstable I mode because I have to have you do that to make me feel good about myself in this context. All right, so that's what we would try and sort of draw out with her, actually. This context she's in is creating terrible disturbance to her I mode, in a way, to her self-esteem, a self-experience in the world. Actually, what is she in the world? And what am I to you? My partner, my husband, the person who's with me, and so on. And when I get into that mindset, I'm teleological. Okay, and that's a very dangerous position because it's very painful. Not only can I feel bad about myself, I actually can't feel good about myself unless you're doing something to give me something or to arrive home on time or whatever. So she's in a little pattern here which would need teasing out. Now, she then says that this particular episode where she's brought, as I understand it, they have some sort of fight because he didn't give up work or something to be with her.
He didn't want to cancel a work trip, and she didn't want him to travel out.
Yeah, she says, I don't want you to travel out. And he says, I'm traveling out, so I don't care what you think, however it can. They have a fight. But again, she's experiencing it teleological, but now it's overwhelming. And then she's overwhelmed and she feels my life isn't worth living. I feel nothing about myself. I'm no good. I've never been any good. I'm unlovable. I'm second choice anyway. And now he doesn't love me. He's shown that through this teleological system. I'm in a terribly painful state because I don't experience my I mode as being worth anything in psychic equivalence. All right. So that's a reality. I die. All right. Now, in a sense, the teleological, did she take an overdose, did you say, or just being suicidal?
Yeah, she tried to cut her wrist, and then she was sort of, not sure if she wanted to end her life, but she was almost there. She was feeling suicidal.
Yeah. So she then has a action which changes her mental state as well, because it makes her, first she got to do something. Well, if I'm no good in some form in psychic equivalence, it's very painful. And actually she has to get rid of that tension somehow. So cutting yourself is a very effective way of reducing a painful, tense internal mental state. But it is a teleological action. It's an action that changes the mental state. So I feel better, I feel less tense, and so on. Right. So she does that, and then she's not sure. Does she want to? Doesn't she want to? Because actually she's a little more stable at that point. In a sense, she's recreated an I, which is not quite as bad as the I am of absolute no worth. All right. Now, in the assessment, we'd simply try to tease some of this out. All right. Now, as a result, we may then have to try to work out actually her sense of appraising her relationship with him again. We may have to consider something to do with MBT couples, which there is, where we organize how they think the mind of the other person is working, how their mind is working. They do that separately, and then we join them up together. So we say, you're now going to tell your partner, your husband in this case, your sense of how his mind works, and he's going to have to respond to that. And then he's going to do the same to you. So we, as it were, do an exercise. So he then has to say how he sees his wife's mind as working, and she then has to respond to that. And then we work with that, because usually there's terrible misunderstanding. Okay, and they need to begin to re-understand each other to some level. But does that help? You begin to de-escalate, explore, find the low mentalizing processes, and then go backwards to find out where they're rooted from. And they're rooting within their interpersonal relationship in some form, which she may have brought some vulnerabilities in. So it's not his fault. She may already have uncertain self-esteem, uncertain, stable self-esteem, and he is actually not able to, as it were, help her with that whilst also getting on with his working or whatever he's doing. So it's all rooted in a single furrow, I think.
Thank you very much for that, Prof. So if it's okay, can we move on to the next case scenario, and then we can take questions at the end. So this is a slightly different scenario where Mr. BR, who's a 27-year-old software engineer, he has been seeing a therapist for 6 months for anxiety related to stress at work, which he's been managing by smoking cannabis daily. But he continues to remain anxious. And then 2 months ago, he lost his job and became deeply depressed. His therapist referred him to a psychiatrist who treated him with an antidepressant. And then during a follow-up with his psychiatrist, he expressed anger with his therapist. He said he didn't want to see her anymore. He had asked her for a reduction in fees because he was out of his job. And she had said they should talk about it. They should also talk about other expenditures that he's managing to continue, like he was smoking cannabis daily. And that had upset him, and he didn't want to see her again. So he was presenting to his psychiatrist, complaining about this therapist, and angry that she, sort of was suggesting that he's spending money on cannabis, but didn't want to spend on therapy.
Was that to the psychiatrist, or then the therapist said?
No, to the psychiatrist. That's what he was relating to the psychiatrist.
Okay. So if I was an MBT mentalizing psychiatrist and somebody comes and says, I don't want to see this therapist anymore, and I'm now depressed, and I'm smoking cannabis all the time, and I say, well, hey, have your antidepressant. And then you say, but I'm not going back to see my therapist. I don't want to see him. He wouldn't reduce his fees. I haven't got a job, and so on. And then the question is, how will a psychiatrist respond to this?
Yeah. Right. And also the thing that upset him with the therapist is she said, yeah, sure, we can talk about the fees. And in the session, she also kind of talked about his other expenditures, that he was spending a lot on cannabis, but didn't want to spend on therapy fees. And so that upset him, and he didn't want to go back to her.
Okay. Now, well, just that little bit, that's a very interesting little scenario, because if our patient comes and tells us something, in MBT, the first thing we've got to decide is are we being told this narrative, or, challenged in this narrative way? Is it held within a mentalizing, reflective, thoughtful system, or is it actually held in low mentalizing mode? Now, you might think, well, that's difficult to separate. But look, if I'm a client and I come along to you, and let's take Ashleisha as the role play. She's my psychiatrist, and I come along and I say, I'm not going back to that therapist. She takes no interest in me. She doesn't care about me. And all she does is ask me about fees, or something. You think, well, you try and explore that, but they kind of come back at you. It's likely to be low mentalizing. If they come along and say, I've got real problems because I need to ask my clinician, or I've asked her, can she reduce my fees because I haven't got a good job? But she says, well, she can think about that, but she's really worried about the fact that I spend most of my money on the cannabis, and she thinks I should reduce that rather than my fees. I can kind of see where she's coming from, but I can't. She thinks I can stop my cannabis, but I'm somewhat addicted. That's a totally different presentation. Do you see what I'm getting at? You sort of think, oh, there's something we can work with to work out what's going on. So the first thing you have to do is decide, when you're told this narrative, how's it being held? How's it being processed in the mind of this person in the moment as they're telling me? Okay? Because in the way they're telling you might be a bit different from how they process it when they told the therapist, for all you know. But so we're interested in actually what's their processing capacity now, because we're going to respond to that. Now, the problem with the clinician, the therapist, was she assumed in some way that this was all being held in mentalizing mode. So she says, look, why don't we be rational about this? You've got this amount of money and you spend that much on your cannabis, but you want me to reduce the fees, but you could just reduce the amount of cannabis, pay me my normal fees, and then we'll get on with therapy. She's trying to rationalize, but you can't rationalize with non-mentalizing, with low mentalizing. You must remember that. So your first step in MBT, are they mentalizing or not? To what degree? And if they're not, don't join with it by arguing with it, because you're pretending they are, if you see what I mean. You say, oh yeah, that's perfectly logical, therapist. Thanks so much. You're absolutely right, of course. But he's saying, I can't stop my cannabis, otherwise my anxiety goes all out. I know, you don't understand me. Do you see what I mean? So the first step in MBT, if I'm the psychiatrist now, not the therapist, I have to take this at face value. I have a patient who feels their clinician, their therapist, doesn't understand them and argues with them a bit and so on, and this, that, and the other. And I'm going to now talk to them about that from an MBT perspective. So I need to find a position with that patient to empathically validate, to say that actually they're angry and they don't want to see them anymore. And actually, I'm picking up a sense that they have a sense that their therapist doesn't really understand what they're struggling with. And that's really what we're talking about. Do you see what I'm getting at? So we have to begin first by empathically validating their sense. They've worked for 6 months. They lost their job, and they have a sense the person they've worked with all this time is not really picking up the seriousness of it in some form. So why don't we work out then how you might communicate that seriousness to them, or how you might think about actually what's preventing them from understanding it, or what you'd really like to let them know about how difficult things are. Do you see what I mean? So you're relatively neutral about whether they go back to the therapist, don't go back to the therapist, but you are actually trying to see it from their point of view, get that elaborated, and then we might be able to think about, well, how do we address this? But that would be the first things to try to do in this situation. Now, if I was the therapist, though, and they came and said, I'm angry, you just think that I could just pay more and I can't, you haven't helped me, and so on, the MBT therapist rolls with that. If my patient comes and says, you're useless, you've done nothing to help me, and now you won't even reduce your fees, you don't give anything about me, you don't care about me. If you cared about me, you would reduce your fees. Do you see what I mean? It's teleological. I know you care and are interested in still seeing me if you reduce your fees, but if you won't, you don't care. Okay, so they're in relatively low mentalizing. The MBT therapist rolls with that. Okay, we have to now see it from their point of view. Actually, I'm getting that. Your sense is that I'm not picking up the seriousness of your current state. You've lost your job, and that's absolutely horrific. Okay, and you've no idea how you're going to manage. And then actually, in a way, I'm saying, well, I'm going to extract as much as I can for you. And I can begin to see how you think, well, I don't care, really. I'm not bothered. Want my money or go home. Do you see what I mean? You're trying to begin to position yourself so that you're with them, not facing them. So we've got a problem here. We've got your sense, and then we've got my sense as a professional, or, you know, whatever. All right. So where are we going to go from here? So you're going to try to stick with them. You're going to pathically validate. If that in itself, which it might, stabilizes mentalizing a little bit, we take responsibility for having destabilized it. Okay, so we now, because of our way of responding, might have created it and made it much more difficult for them. Okay, so we take some responsibility in this creation of a therapeutic rupture. It's not them just being difficult or non-mentalizing. We're part of it. So we usually try to also take it back. So we might in MBT say, can we just rewind, you know, when you told me about this and how things have gone from bad to worse, in a sense, between us? Because I think maybe I've contributed to that by perhaps not responding. You know, like when I tried to persuade you to stop cannabis. I can really see how that can be really irritating. It sounds so rational. Do you see what I mean? We would take some responsibility for jointly creating the rupture. So it's not all on the patient. They feel very relieved by that, and it very often makes them experience a sense that they're not just the abnormal one in the world. They're no longer alone, you see. They sort of share it across a little bit. And that's what you're trying to do.
Thank you so much for that. We'll do the last case as well, and then if we have time, we can take some more.
By the way, you would try to stop them smoking too much cannabis, by the way.
Yeah, absolutely.
But that would have come in the formulation at the beginning, that cannabis is a way of changing mental states, which actually make it really problematic to process other memories and mental interaction. So,
yeah. This is quite a common, problem. I use cannabis as one of the examples, but it's often other things where we know that the sort of patients are doing other things. You know, they're having an extravagant lifestyle, but they want the therapist to not to pay the therapist fees. So it becomes quite a difficult situation. But thank you for that, Professor. So the last case is another common scenario. So this is Miss SD. She's a 14-year-old who's complaining to her school counselor. She feels her parents don't care about her at all. They don't want her to have any friends and are making things worse for her because they want her to stop using her phone at 11 p.m., which is very unfair. She feels that 10 p.m. to 1 a.m. is the best time for her to study. It's when all her friends are online. She can clear her doubts. But her parents are worried for her because she's been bullied online before, and most of it happens late at night. She also struggles then to get up in the morning and reach school on time, misses breakfast and not eating, and sort of using food as a way of either, comforting her or avoiding it completely is a problem that they're running in with her. So for them, it's like, if you sleep late, then you don't get up on time, you don't eat, and then you're hungry when you come, and then you're binging. So this is the conversation that always happens at home and causes a lot of conflict, and she's complaining to the school counselor. Yeah.
Well, good luck. All parents the world over, hell. Yeah. Oh dear. Yeah, we tend to become more coercive and punitive as parents, don't we? We kind of switch off the phone or remove it or put on something that blocks them. Oh God. Anyway, all right. Okay, she's 14, problem. Okay, yeah. Well, MBT for adolescents, it takes a particular form, let's just mention that, but it does include the parents and school. Okay, so it takes a more system than individual approach, for one thing. The second thing it does in some forms, MBT for adolescents, MBTA, is also use peer group. So we use a group because they will, as it were, function and listen to their peer group rather than the parental group, you know, grown-up therapists or school counselors or teachers, you know, they're the enemy in a way. So we often run a MBTA group, and then the parents may be also involved. So there may be some family work as well. So sometimes individual plus family, or family plus group, and so on. It depends a little bit. Okay, so you're trying to organize the system around the person as well. Right? That's very important, obviously. Now we've then got a 14-year-old who experiences her parents as not caring or not understanding her needs. I'm best at this. This is when I need it. This, you know, da-di-da-di-da. And they point out that, no, you don't. You're late. You don't get up. It's disordered your eating. You know, you're a mess. Okay. The problem is they think, in a way, understandably, that the mess will be improved or remedied if we get rid of your phone. Unfortunately, it won't, because the phone use is probably not the key, if you see what I mean. So that's the first thing. They have a low mentalizing. I need this now because this. It's probably lowish mentalizing. We'd expect a 14-year-old to have problems of mentalizing. We all, in the sense they're developmental. I mean, you know, they're not fully formed. Our mentalizing doesn't stabilize till, say, 25. So, you know, she's anyway, as it were, learning. And in adolescence, there's a very strong attempts, of course, for self-agency, autonomy, and those sorts of things, separation, and generating an experiential self that's stable, because it's not at 14. So some of her actions might well be an attempt to become a person, you see what I mean, and so on. So we would in MBT see her. We just try to see what she's getting from this, what her own appraisal of it's like, what her sense is. But we'd also actually get to the sense of how painful it is when she thinks her parents don't understand her at all. So their relationship is an issue. And we need to think about that. So we try to get it into that sort of thing. But we're also, I'd be concerned because she's experiencing bullying. And in a sense, the bullied actually has as many problems as the bullier, if you see what I mean, and so on. And her parents are rightly not trying to stand by. They want to be involved. They're trying to be involved. The trouble is they're not quite sure how to be involved. That's helpful. So that's why we'd have to involve them. But she herself might not be able to protect herself in many ways and things like that. So she's got sort of self-appraisal problems. I don't know what the bullying is, but does she, for example, trust in people she shouldn't be trusting in? That sort of thing. And then they exploit her, or they undermine her and then exploit her, and things like that, get her to do things and so on, and things like this. So she might be vulnerable. So we do quite a bit of work with her. And again, it has to take the not knowing stance. It has to see it from her perspective. It certainly has to try to begin to take her perspective first, before you try to get her to consider her parents' perspective or the school teacher's perspective or anyone else's perspective, because that will make her feel not listened to or not understood. So we'd start with her I mode experience and her me mode sort of sense first, not always trying to get her to consider the other people's mind, but certainly maybe her personalized me mode, maybe how she thinks they see her all the time. Okay. All right, that'd be sort of where we'd go.
Thank you for that, Prof. I mean, actually, just as you were talking about with adolescents, you do a peer group. We found that as well. Our most recent group that we just completed, we have to we are hoping to write it up. We don't have anything to compare it with, but it's just, that was the most, even, I mean, I wouldn't say I was as old as their parents, but I was definitely older than them. And, or probably was as old as their parents, but they were much more likely to get their mentalizing restored in the presence of their peers. And of course, at some point when they become attached to the peers in the group, then their mentalizing is lost because they start feeling, whatever, hurt by someone else. But there's definitely all these things with relation to phone and how they viewed themselves it also gets discussed. And it's interesting how they come up with, they're able to notice that the other person is not quite mentalizing. They're, focusing too much on one thing or the other. And it helps a lot with the groups when you're working with adolescents.
Yeah, I absolutely agree. And you can see that in the groups, the adolescents, that they are very quick at picking each other's up, picking each other up much quicker than we are, and things like that. And they can also be a bit more challenging to each other than we might be, and things like that. So I'm glad you found that it's incredibly effective at that level.
So thank you so much. I think those are the 3 cases that we wanted to just run by everyone, just so they get a flavor of the different situations in which like a framework of mentalizing and MBT can be applied. Does anyone have any more questions? I think we have some questions in the chat.
There's one about narcissistic, and they're in trouble. The mum's got untreated BPD, and the partner has an older parent with strong narcissistic traits. So they got a double problem. Is that right? Well, yeah, okay, you're in trouble. But it depends how that's sort of operating in the system, of course, and to what degree somebody has gained a certain level of autonomy as well, so that they're less taken over by the narcissism of the elder parent or something like that, or they're less reactive or responsive to the BPD sort of symptoms and so on of the mother and things like that. So it just rather depends how to manage that, I think. And Kapil, the theory suggests, yeah, that's correct. Disorganized attachment is the one we're really worried about, because it leads to profound mentalizing difficulties, actually. And that's in the empirical literature. You can read about that. It's interesting, if they start stabilizing mentalizing, do their attachment sort of processes shift? We would predict that they would, but I think the difficult bit is that attachment activation in adulthood, we're talking now, is of course a rather complex affair. It's not just insecure or secure, if you see what I mean. I mean, it is to some level, but it's not a translation from their attachment strategies of childhood, which equals how they are in adulthood. It's a very complex sort of component. So in a way, in adulthood, we might get a pattern that's very common. And I think that can change if your mentalizing stabilizes. But I don't think you necessarily would expect to move from insecure to secure, for example, that sort of level of shift overall. Now, there is some literature that suggests you do change actually your attachment sort of style overall. So, but anyway, it's such a complex kind of way, a relational sort of processing. I'm not sure we measure it very well.
Prof, I have a question about the attachment kind of system or the strategies that we see commonly in the borderline kind of personality population. So I was a part of the introductory MBT sort of training that you did, and we have this peer group that we sort of meet regularly. I see patients quite, and a part of this peer review group here. So we sort of traditionally taught, like as per literature, that there is some level of stability of attachment through life. But what in clinical population that we are often observing that, you have this avoidant, anxious / fearful, avoidant kind of category of patients who have some sort of trauma that is developmental, which is either parental invalidation or some sort of abuse, physical, sexual, that spectrum. So they have this kind of fearful avoidance system when they are with, let's say, peers, close friends. But they start sort of behaving slightly differently, let's say, when they become romantically involved. So I'm just sort of wondering your experience and maybe your views and what you have seen. And do you see this quite commonly, that they display kind of various proximity seeking strategies depending on the system or the group that they are in? Is that common?
Yeah, I think it is common. And we know in borderline personality functioning that they have particular strategies in adulthood that tend to be activated. And you're absolutely right. I think what you're seeing and describing is the sort of translation towards adulthood of more disorganized attachment processes. So you get anxious avoidant, you get anxious ambivalent, you get over-involvement as well. And you get components in different contexts. And it's a bit unpredictable and things like that. It continues across time in this rather, what appears a bit random, but it's also very sensitive attachment processes. So they're continually activated in all sorts of situations and so on, and interactions with people, not just intimacy. It could be in a shop and so on, and things like that, and so on, when they're with them. So you're absolutely right. And they tend to be very, they're a bit like, I always think they're a bit like sort of geysers that shoot up out of the ground and then suddenly they're off and then it's gone again and then something else appears and it's gone again and so on.
I think the more confusion that we see is that in particular sort of cohort of groups, they become more avoidant when they're anxious instead of sort of proximity seeking. In romantic relations, they become more preoccupied. They sort of become...
That's right. Yeah, no, that's absolutely right. And that's in the literature, in the empirical literature.
Latika has a hand raised. Latika, do you want?
Thank you. I do have two questions, and you can tell me if they're not so related to empathy, but they are related to attachment. So we know that the parent's attachment pattern can really impact the attachment pattern of the child. But there are some studies that say, and you can correct me if I'm wrong, I know that maybe I'm isolating one study and applying it, says that even 30% of attunement or 30% of sort of presence is good enough parenting. There's this particular number that's going around. I wonder what are your observations in your practice and in especially with, again, parents who have BPD or personality conditions. So then we know that for a fact that they don't have secure attachment. Are they able to, with therapeutic support, nurture a secure attachment in the child is one question. Second,
could I just, because your sound is was a bit problematic for me. Could you just summarize?
So I can repeat that question. So what I think, Latika, you're asking is that parents' own attachment style can have an impact on the child's attachment. And if we know that a parent had poor attachment with their parent, and if there is a therapeutic intervention that improves their capacity to care for the child differently than they were cared for, and if that improvement, is it sufficient to improve their, and is it enough for the child? And what she was quoting is a study where it says that all a child needs is a 30% attunement, not like a 100%.
Yeah. You don't need 100% attunement. Yeah. So you can train the mums to some degree to actually mentalize the baby, as it were, the child, before the child's born. So it's not just after birth, because we know that actually the attachment process may well be measurable prior to birth, as it were. So in the mind of the mum having a baby, if you see what I mean, So you'd start beforehand, and you would actually try to be helping them begin to consider and attune to the baby's needs, the baby mental states, the baby emotional states as they build in complexity. And you can use all sorts of things. In minding the baby, they might use video feedback and these sorts of things and discussion around it, making sure you don't shame the mum for not understanding and these sorts of things. So yeah, and you don't have to be 100% attuned. This is not going to work. We're not 100% attuned, so 60% is fine, and 30% I think might be a bit low, but yeah. Okay, so I would say yes to that, certainly, and there are many studies around that.
I have one more question, if you don't mind. So BPD is now maybe being considered as a neurodivergent condition that's not so separate, like separate from ADHD or autism. And hence I was wondering, what is the applicability of MBT in other such neurodivergent conditions where black and white thinking might be prominent, or similar forms of low mentalizing, maybe?
Yeah, we don't actually know, but what we say is that you have to praise their mentalizing. You're not appraising their condition. We're not trying to differentiate ADHD from autistic spectrum disorder, from borderline personality disorder, from complex PTSD. We're not trying to make a diagnostic categorical system. We're on a dimensional system. So we're interested in actually their mentalizing profile, what that looks like, and what context it shifts and changes, whether it's variable or whether it's fixed, all these things. And then once you've done that, there may be a question about what's creating that. So I do think that the creation of autistic spectrum disorder mentalizing problems is quite different from borderline personality disorder mentalizing creation problems, the creation of do you see what I'm getting at? The same applies to some extent to complex PTSD. All patients with borderline personality have not experienced PTSD, trauma. They haven't done. So it's not one-to-one type thing or categorical difference and so on. So there are people who are looking at autistic spectrum disorder, even at the severe end. Simon Baron-Cohen creates mentalizing training sort of exercises using online stuff and on computer stuff with people with severe autism in social cognitive processing training, if you like. But it's a mentalizing based training system. So, there are people trying to do this, because you don't have to say, oh yeah, MBT is only good for BPD, but it's no good for that autistic spectrum, is it? They're all neurodiverse, but it's no good for that. Yeah, come on, the brain's not like that. The mind's not like that. Mental health illness, mental health problems are not like that either. Do you know what I mean? So.
Thank you so much for that, Prof. We'll take one last question where Shri, who's a practicing clinical psychologist, and they're asking, in what ways would an ongoing experience, such as ongoing abuse or domestic violence, affect the mentalizing process? Yeah.
Okay, well, domestic violence, I'm not sure where the mentalizing problem you're suggesting is. This is in the violent person or the abused?
The abused, I imagine. So
yeah, I imagine, but it's highly likely they've both got mentalizing issues and so on. So in domestic abuse, though, in the antisocial personality disorder, we're often treating in MBT the abuser. Okay, but in borderline personalities, we're more often helping this person who is the victim. And MBT is probably useful for both to a large extent. And the problem in domestic abuse is sometimes is that the person becomes trapped in it, the abused. And there can be practical social reasons for that. There could be marriage reasons, cultural reasons. There's all sorts of things that they can't extricate themselves. And there's also psychological reasons. So it's actually a big problem for them to become self-assertive, or to actually not experience themselves, for example, as being the cause of the abuse by deserving it, for example. Okay, so they're manipulated by the abuser and things like that. It may not be just physical abuse, it could be psychological, coercive control abuse, where they experience a sense that it's their fault and they deserve to be treated like that. So it's an amazingly complex interaction. But nevertheless, you have to get them out, or help them get out of what might be a dangerous situation, for example, and so on. Anyway, it's a whole complex area, isn't it? And then depression, yeah, there's a study with third wave CBT versus MBT for depression, and MBT did very well in that study. I have to say they on the Hamilton rating scale for depression, the third wave CBT group did marginally better, but it's very, very tiny. So clearly MBT has reasonable effect size in moderate to severe depression. So you can have a look at that study. It's a Danish study.
Prof, another just experience that I want to share that we just discussed in our group. So we do see, I and sort of our group, we do see a lot of patients who have had some form of developmental trauma that is non-sexual abuse, mainly sort of family challenges, invalidation. So they sort of come to develop, have a cluster C kind of personality organization with predominant kind of social anxiety, some level of dysregulation, self-esteem kind of issues. So sort of they seem to simulate someone who has a lot of external focus, teleological kind of representation in kind of social interaction. So MBT as a method is sort of being I've sort of been using that, and that is sort of working reasonably okay. Not obviously evaluated, just an experience that I thought I'll share.
Well, thank you. That'll encourage perhaps other people, because it does, empirically it works, but that's not quite the same as it working when we sit behind a closed door in our private practice or in our clinic somewhere, on our own and things like that. We know that clinical practice is a bit different from research practice, but actually in general, clinicians find that MBT adds something to their sort of way of working with people, and it is genuinely helpful, I think.
Yes, definitely so. Thank you so much, Prof. We'll also be sharing the flyer of our upcoming training. So the basic training is at the end of February in Bangalore, and it will be held in Frasertown, 24th, 25th, and 26th of February in person. If you have any more questions about it, you can email us. We'll be sharing the flyer with you by email anyway. If you have any other questions about, people who are practicing MBT in India, we can also send you more information about that. We want more people to be practicing it, and also, to be able to address questions like Latika you had about how much benefit does it have in our population. And we'll only know if we have more people, and we can do larger studies, comparative studies. So until then, it's just going to be us sort of, in smaller groups doing this work. So thank you so much. Thank you, Professor. I feel like whenever I listen to you, I always learn something new. And it was really wonderful listening to you go through that introduction. And I'm sure people who want to know more. So do email us, and we look forward to welcoming you in India very soon. Thank you, everyone, for joining us, even though it is quite late.
Thank you.
Thanks, everybody. Bye. Bye, everybody.
Thank you.